Hello and good morning. My name is Jennifer Gutierrez, and I'll be discussing abnormalities of the male breast today. A few objectives for the presentation. We'll be discussing the clinical presentations of benign and malignant processes that we'll see in the male breast. We'll be reviewing some initial imaging workup of the lesions, and also, of course, the salient imaging features that we need to be aware of for the different breast conditions that allows for accurate imaging interpretation and to decide whether biopsy is needed or not. As an overview, conditions related to ductal and stromal proliferation may occur in men. These include gynecomastia, invasive ductal carcinoma, DCIS, and papillary neoplasms. Breast conditions that involve lobular proliferation are rare in men. Fibroadenomas, phylloides tumors, invasive lobular carcinoma, LCIS are typically things that we see in women primarily. Initial imaging workup for any breast disease in the male. Mammography is the initial imaging modality for any suspicious finding. Palpable mass that is occult on mammogram should always be sent to ultrasound for targeted evaluation. Suspicious or indeterminate masses require biopsy. Most often these are performed with stereotactic or ultrasound-guided technique. So to start off, our most common condition we see in the male patient is gynecomastia, of course. It has a bimodal prevalence. First peak we'll see near puberty in young men, and a second peak in the 50s. Proliferation of ductal and stromal tissue elements causes gynecomastia. It can be unilateral or bilateral. Pseudogynecomastia is seen in obese and overweight patients. Breast enlargement is seen rather than a focal palpable mass in these patients. And on the table, you'll see different causes of gynecomastia. It varies. Physiologic causes, of course, that we discussed, puberty and advanced age. Drugs can cause gynecomastia. Different hormonal imbalances as well can be seen as the root. Gynecomastia versus breast cancer is really one of the big questions that pops up when a male patient presents. We always want to make sure that we're excluding malignancy in these patients that have a palpable lump. Gynecomastia is more common in the subarular region as opposed to male breast cancer, which can occur in any part of the breast, and it does tend to spare the subarular region and the nipple. The presentation for gynecomastia is usually unilateral breast pain rather than bilateral, but often you can see that gynecomastia is in both of the breasts when you do the mammogram. It may be asymmetric, however, with one side much more prominent where they're having the pain. Palpable subarular breast masses can also be seen at presentation of gynecomastia, and you can also have breast enlargement. Other symptoms of gynecomastia that are less common and most often associated with breast cancer or papilloma are nipple retraction, bleeding, nipple discharge. Those are always considered clinically suspicious and should definitely raise your eyebrow and lead you to further workup. There's a very low prevalence of male breast cancer under age 30. So most of these patients who are young men with breast symptoms will have gynecomastia as opposed to breast cancer. 3 mammographic imaging patterns of gynecomastia can be seen: nodular, dendritic, and diffuse glandular. Nodular pattern is typically early on within the first year. They typically present with a painful breast mass or enlargement. You will see that classic fan-shaped subarular density. And if the stimulus of the hormonal imbalance or whatever is causing the gynecomastia is removed, often these imaging findings are resolved. The dendritic phase is more fibrotic and can cause irreversible abnormalities. Mammogram shows a flame-shaped subareolar density that can extend from the areolar region to the upper outer quadrant. And diffuse glandular is much more prominent and usually the result of high-dose estrogen therapy in men. Mammogram can show dense breasts with both nodular and dendritic components, often resembling female breast tissue. For case 1, we have a 75-year-old male with a subareolar palpable mass. The left MLO view shows a triangular flame-shaped subareolar density with linear projections radiating into the surrounding fat. These are very classic mammographic findings for dendritic gynecomastia. On ultrasound, we have an ill-defined hypoechoic mass with spiculated margins and suspicious shadowing. Findings on ultrasound with gynecomastia can be very deceiving as they look more suspicious compared to the mammographic findings. So the mammographic appearance of gynecomastia should outweigh the sonographic appearance if it does look very benign on mammogram. Imaging workup should always begin with mammogram, therefore, since ultrasound findings can be indeterminate or even suspicious, such as this one above. Mammography has a high sensitivity and high specificity when differentiating between benign and malignant breast disease. So that is why it is the first initial imaging modality for men. In case 2, we have a 62-year-old male with a palpable breast mass. Right CC view shows an irregular subareolar mass. On ultrasound, we see a suspicious irregular hypoechoic vascular mass. Biopsy demonstrated gynecomastia. This did go to biopsy, of course, because it did have suspicious features on both mammogram and ultrasound. Gynecomastia can often mimic malignancy, leading to biopsy or excision. In case 3, we have a 64-year-old male with right breast pain. MRI image shows a nodular enhancing area and a ductal distribution in the right breast with suspicious enhancement kinetics, as seen with the arrow. MRI imaging guided biopsy was performed and did demonstrate gynecomastia, again mimicking malignancy in this patient. The treatment for gynecomastia really starts with clinical evaluation. Hormonal imbalances can occur during puberty, and then you can have spontaneous regression in a majority of these cases. If there is an identifiable cause, a stimulus that can be removed, of course, we want to discontinue that offending medicine or treatment, and this can also result in regression unless it's reached that irreversible fibrotic phase that we discussed earlier. Hormonal modulator and inhibitor therapies may also help gynecomastia in some patients where the symptoms are unacceptable or refractory to treatment. Reduction mammoplasty can be an option for these men. Male breast cancer, our next topic. Any peripheral or eccentric mass or non-contiguous asymmetric density is suspicious and should warrant biopsy. Approximately 0.7% of breast cancers occur in men, so much less common, of course, but definitely still happens, and I see it in clinical practice as well. Men with breast cancer often present at a more advanced stage in women due to the delay in diagnosis. Approximately 50% of men with breast cancer can have nodal metastasis to their axilla at initial evaluation. Clinical presentation of male breast cancer can manifest as a painless, palpable mass. You can have nipple ulceration or retraction, nipple discharge, skin thickening, palpable axillary adenopathy, usually unilateral. but you can't have bilateral in less than 1% of cases. Occasionally in the subarular region, but more commonly, like we said, in other parts of the breast. Risk factors for male breast cancer include the BRCA1 and 2 mutations, family history of breast cancer and first-degree relatives, Klinefelter syndrome, hyperestrogenism, advanced age, history of chest radiation, and history of exogenous estrogen treatment as well. Initial imaging workup for male breast cancer should include mammogram, of course, initially. Bilateral CC and MLO views should be performed even if the clinical findings are unilateral. Targeted ultrasound is performed for suspicious mammographic findings. And of course, if the mass that is palpable is not seen on mammogram. Biopsy is required for any suspicious finding on mammogram or ultrasound, and typically ultrasound-guided biopsies are performed. For case 1, we have a 76-year-old man with a 1-month history of a palpable breast mass. The right MLO view shows a subarular mass with ill-defined margins and abnormal right axillary lymph nodes. Ultrasound imaging showed a heterogeneous solid mass with ill-defined margins and internal vascularity. Axillary autoanopathy was also present, though not seen on this slide. Pathology showed invasive ductal carcinoma at biopsy. For case 2, we have an 88-year-old male with a breast mass and bloody nipple discharge at presentation. The left CC view shows a dense mass with indistinct margins. Ultrasound imaging shows a complex cystic mass with posterior acoustic enhancement and indistinct margins. So this was a little bit different from other cases of male breast cancer that you can see that can have prominent posterior shadowing as opposed to posterior acoustic enhancement. So we know that there is some type of fluid component within this suspicious mass. MRI imaging shows a complex subarular mass with a thick nodular enhancing rim. Biopsy did demonstrate focal infiltrating ductal carcinoma with associated hemorrhagic component. In case 3, we have a 56-year-old male with intermittent spontaneous bloody nipple discharge. Left MLO view shows a focal lobulated subarular mass with evidence of both punctate and coarse calcifications. Biopsy demonstrated DCIS. Case 4, we have an 83-year-old male with nipple retraction. Left magnification views showed a dense spiculated subarular mass with skin thickening and nipple retraction. Targeted ultrasound showed an irregular hypoechoic mass. Biopsy demonstrated infiltrating mammary carcinoma with ductal and lobular features for this patient. So to discuss some various benign breast conditions in men. So some benign non-neoplastic breast entities that you'll see in men are intramammary lymph nodes, sebaceous cysts, diabetic mastopathy, hematomas, fat necrosis from trauma, subarular abscess, breast augmentation, venous malformation, secondary syphilis, and nodular fasciitis. Benign breast neoplasms in men include angiomyolipomas, schwannomas, intraductal papillomas, and lipomas as well. In case 1, we have a 49-year-old male with non-tender palpable mass. Left MLO view shows a mass of mixed fat and soft tissue density. Ultrasound images showed a well-circumscribed homogeneous echogenic mass. Biopsy demonstrated findings consistent with an angiomyolipoma. This accounts for about 5 to 17% of benign fatty tumors in the body, but they are very rare in the breast. In case 2, we have a 33-year-old male with a soft palpable mass. Right CC view shows a sub-centimeter well-defined mass. Ultrasound imaging showed a complex hypoechoic mass with eccentric internal vascularity. Biopsy demonstrated findings consistent with a schwannoma. These are rare. They arise from the Schwann cells of peripheral nerve sheaths. They can be associated with neurofibromatosis type 2, and if they are associated with that syndrome, you have a higher potential for malignant transformation. This is rare, however, but it does have a poor prognosis. In case 3, we have a 73-year-old male with clear spontaneous nipple discharge. Targeted ultrasound shows of the right breast shows 0.5 centimeter lobulated solid intraluminal mass within a dilated duct, demonstrating internal hypervascularity. Biopsy demonstrated findings consistent with an intraductal papilloma. So intraductal papillomas are solitary, usually, and located in the central breast. They manifest as nipple discharge or palpable subarular masses. Ultrasound is more sensitive than mammography. And if ultrasound is negative in a patient with a suspicious history of bloody or clear spontaneous nipple discharge, additional workup is always indicated with surgical consultation and possibly even MRI. A negative ultrasound should not exclude an intraductal papilloma. Because of false negative results from a non-distended duct at imaging. If biopsy demonstrates an intraductal papilloma, surgical excision is indicated for all papillary lesions due to sampling error and histologic underestimation of the lesion. Some of these can be upgraded to papillary carcinoma, so it's important to have all of these papillomas excised after diagnosis at core biopsy. In case 4, we have a 49-year-old with a palpable breast mass. Left MLO view shows an encapsulated radiolucent lesion of fat density. Mammogram appearance is diagnostic of a lipoma. These are benign tumors of mature fat cells. Ultrasound shows a mildly hyperechoic avascular oval mass. They can also be hypoechoic or isoechoic relative to subcutaneous fat, but have a very, very benign appearance on mammogram, which should outweigh ultrasound features. In case 5, we have a 47-year-old male with a 2 to 3 history of a palpable breast mass. Right ML view shows a well-circumscribed mass with macrolobulated margins. We have ultrasound imaging showing a 1 centimeter macrolobulated reniform-shaped mass with a hypoechoic cortex and an echogenic hilum. Very benign features, but the patient did request tissue sampling of this lesion, and it was demonstrated to be a benign lymph node. So intramural lymph nodes can be seen often in the upper outer quadrant, but can be anywhere in the breast. The normal lymph nodes that we see should have a thin cortex, echogenic cortex and echogenic hyla. Abnormal intramammary lymph nodes are more than 1 centimeter in short axis dimension and are not fatty appearing. They're typically round or irregular shaped and can have cortical thickening. In case 6, we have a 64-year-old with a palpable breast lesion. Ultrasound image showed a well-circumscribed oval mass in the subcutaneous tissue, and that was compatible with a sebaceous cyst. Sebaceous cysts are benign intradermal lesions due to an obstructed sebaceous gland. They're usually smaller than epidermal inclusion cysts, but they are indistinguishable at imaging. You can see hyperemia if the cyst is inflamed, but it should really never have internal blood flow. It is considered a do not biopsy lesion because there is risk of inflammatory response resulting in abscess formation if the cyst is ruptured. In case 7, we have a 36-year-old male with diabetes, and he presents with a palpable breast mass. Left CC view shows an irregular subarular mass. Ultrasound image shows a hypoechoic region with indistinct margins and posterior acoustical shadowing. Biopsy demonstrated diabetic mastopathy for this patient. Diabetic mastopathy is a rare fibroinflammatory breast disease in men, typically in long-standing type 1 diabetic patients. Mammogram shows a nonspecific discrete mass or regional asymmetry. Ultrasound can show single or multiple masses, and they're typically hypo or avascular. This can mimic breast cancer because of the appearance of kind of a nonspecific discrete mass on mammogram. biopsy is often required for these lesions. Surgical excision is not indicated, however, because there is no known increased risk of malignancy or malignant transformation in these lesions. In case 8, we have a 40-year-old man with a 3-month history of a breast mass after direct trauma to the breast. Right ML view shows a mass with air fluid levels. On ultrasound, we have a large mixed solid cystic mass with internal echoes and a fluid debris level. There was non-adherent avascular debris seen in the decubitus position as well. The lesion was aspirated and demonstrated a fat fluid level in the syringe, therefore compatible with a posttraumatic subacute hematoma with fat necrosis. So posttraumatic hematomas and fat necrosis are benign findings. They can be from trauma or breast surgery. Even though the trauma may be trivial, they can cause clinical symptoms and imaging abnormalities, especially in the patients who have some type of coagulopathy or are on anticoagulation treatment at that time. There are variable appearance on imaging of the hematomas because it depends totally on the time frame of the event. So on the acute findings, we have atypical masses that can be seen and skin thickening, which can mimic breast cancer or a breast abscess on mammogram. For subacute hematomas, we have discrete masses that can be seen with internal fluid levels, fat necrosis from injury to the breast fat. These can evolve into discrete masses with fat fluid levels as well. For chronic hematomas, it's very variable. You can have persistent round masses, you can have distortion, you can even have just dystrophic calcifications. In case 9, we have a 64-year-old male with nipple swelling and brownish nipple discharge. Left magnification views shows an irregular subarular mass with surrounding trabecular thickening. Ultrasound imaging shows a complex hypoechoic solid cystic subarular mass with posterior acoustic enhancement and internal vascularity. Surgical excision of the suspicious mass demonstrated an obstructive duct with chronic inflammation and squamatization. Subarular breast abscess is a localized infection, most secondary to ductal ectasia, chronic obstruction, and inflammation. Most abscesses in the breast are seen in the subarular region, but can be present elsewhere. They are most commonly caused by Staphylococcus aureus or Staphylococcus epidermidis. You can see pain, nipple swelling, nipple discharge, and mammogram shows ill-defined subarular masses. Ultrasound shows a complex mass and increased peripheral vascularity in most cases. You can have absent internal vascular flow, and you can have occasional prominent internal flow. When you do see that prominent internal flow, biopsy or excision is indicated because malignancy can have a very similar appearance. So subarular breast masses can also mimic gynecomastia. Clinical findings are important to take note of, including skin thickening, regional erythema, other infectious symptoms that the patient may have, systemic like fever or other signs of inflammation. Antibiotic therapy and ultrasound-guided drainage can be performed for treatment. Recurrent abscesses do require excision in many cases. An excision should include both the abscess and the adjacent lactiferous ducts to prevent recurrence. So as we've discussed, most breast findings in men are benign and have characteristic features on imaging. Identifying these features will allow accurate imaging interpretation and can potentially avoid unnecessary tissue sampling. Mammography, sonography, and MR imaging allow for a complete workup of these lesions, and they are necessary to identify the small subset of male patients who need biopsy for lesions that are suspicious for malignancy. Thank you for listening. This presentation was performed with permission from Radiographics and RSNA. Thank you and have a great day.